So we're now going to cover some common clinical scenarios, and first of all we're going to have a patient with a cervical disc prolapse. So Tom's come to see me today in my consulting room. About 6 weeks ago he had a relatively abrupt onset of severe pain in his neck. He woke up with it one morning and couldn't remember doing anything unusual either the preceding night or in the week leading up to the onset. He noticed that his neck was extremely stiff, that he could hardly move his head at all, and over the next 48 hours he gradually began to develop pain radiating down through the shoulder blade and shoulder itself, and then down the outside of the arm into the thumb and first finger. The pain is very severe, it's shooting pain, made worse by any sort of movement either of his head or of his arm. Relieved to some extent with anti-inflammatories and stronger codeine-based analgesics. So he put up with this pain for the first 3 or 4 days, wasn't getting any better, went to see his general practitioner who increased his analgesics and also recommended some physiotherapy. Now the physiotherapy was helpful in some respects in that it helped with the neck pain, but unfortunately every time he went to go for physiotherapy it made the arm pain worse. He also noticed that every time that he coughed or sneezed or was straining, for example passing stool, that the pain in his arm would get much worse. So clearly the GP was worried that he might have a cervical disc prolapse, and that's why he's been sent up to see us today. So 6 weeks of severe neck and arm pain that hasn't responded to conservative measures. So I'm going to examine Tom, and the first thing you notice, he's holding his head very stiffly, and when I feel for the muscle tone, these muscles are very, very tight and in spasm, and I can hardly press into them at all. Then if you turn this way, and when I come to examine Tom's neck movements, you'll see that they're very, very restricted. So try and put your chin down on your chest, and he really doesn't like doing that. Very restricted. Look up towards the ceiling, and again he can just get his eyes above the horizon, but any movement of the head is bringing on some pain in his arm. And often the movement that makes the pain worse is lateral flexion, particularly towards the side, the affected side. So just try not to hurt you, but just try and move your head towards the affected arm. And he really doesn't like doing that, and as he does that make the pain in your arm worse? Okay, and then move your head, try and bend towards the other side, a little bit more movement there, and then look straight ahead. And you'll find that the rotation is often reasonably well preserved. If you turn your head to the left, yeah, and then to the right, and that's not making the pain in his arm worse. So having established that the neck he's got muscle spasm with a reduced range of movement, we're now going to look at the neurological findings in the arms. So I think perhaps if you lie on the couch for me. Now Tom has described pain in the C6 dermatome. So the findings that we might expect to find are that the supinator reflex are depressed, and he has some altered pinprick sensation over the thumb and first finger. So I'll just check his reflexes now. So looking for the biceps, which is predominantly C5, which is present, and then going for C6, and the reflex is not there. And looking at C7, and there's a little reflex there. So we found that the supinator reflex is absent. It's quite unusual with a C6 root problem to find weakness in the arm. Sometimes you'll find a little bit of weakness of elbow flexion. Just bend your arm up towards you. No, but it's not there. He's got a good power of elbow flexion. And we'll just test sensation. So you put your hand into this position and always test the area where you expect the pinprick to be normal. Can you feel the pin there, Tom?
Yeah.
That's fine. And then if we work our way down through the C5 dermatome, and then as we come down into C6, particularly the thumb and first finger, you notice that alteration in pinprick sensation? Does it feel a little bit different?
Yeah, it's less sharp.
Less sharp, that's right. And then when we come over here, sharp again?
Yeah.
So we're into C7 here, but when we test in C6, you notice a little bit of blunting of the pin. The natural history of cervical disc prolapse is usually very favourable. Most patients will get better, provided they are prepared to wait. By 6 weeks, roughly 50% of patients with radicular pain in the arm from a cervical disc prolapse will have made a complete recovery in the sense that their arm pain will have resolved. By 3 months, 70% of patients will be better, and by a year, 95%. But for those patients who have severe arm pain, which is not settled in the first 6 weeks, you need to consider alternatives to conservative treatment. And the two main alternatives that we can think about are either undertaking a cervical nerve root injection. The advantage of that is it will provide some pain relief while we're awaiting the natural resolution of the problem, or if the pain is severe and if an MRI scan has revealed a significant disc with nerve root compression, then an operation to relieve the pressure on the nerve root should be considered. And surgery these days is very safe and very effective, and we're looking to cure 95% of patients. So 95% of patients having an operation under these circumstances, we would expect resolution of their arm pain. And if you cure the arm pain, you almost always cure the neck pain as well.